so that there are no clinical situations in which the specific etiology microorganism in osteomyelitis is predictable. Therefore, cultures of the involved bone or of the involved contiguous tissues are always necessary to get the job done diagnostically. And then you'll see that therapeutics are dependent upon that diagnostic accuracy. So I'd like to just spend a very short period of time going over hematogenous osteomyelitis as it affects the long bones in children and in adults, but mainly in children, and then how it affects vertebra in adults, to get the pathogenesis down so that you see how the pathogenesis relates directly to what we need to do and what we need to affect adequate therapy. So the roots of infection for osteomyelitis are hematogenous, introduced, and contiguous. And the hematogenous root is divided into two groups for childhood and for adults. And in childhood, it's mainly in the long bones because that's where most of the blood supply in growing people goes to in terms of the skeletal system. And it's usually at the metaphysis, which is a broad cancellous bone at the end of the shaft. It's a very active metabolically, has a very rich blood flow, and that's why it makes sense that it would be the initial infective site. The vasculature there is predisposed to infection because there's a deficient number of phagocytes. Deficient is not the right word. Bone normally does not have a lot of phagocytes. Even when there's an infection in bone, there's not a lot of phagocytes, and that's why the pathologist will often search around for some time to show that there's a polymorphonucleoleucocyte there in order to even make the diagnosis histopathologically that bone infection is present. So there's not a lot of phagocytes there inherently. And then you have non-anastomosing nutrient arteries, and so if one becomes blocked, then you have automatic ischemia because there's no collaterals. And then on the venous side, the sinusoids are wide, therefore they have slow flow, which is turbulent, and then that leads to easier blockage. And when you block the veins, then you wind up with arterial flow coming in and no venous outflow, and so you wind up building up pressure in the system, and so you get increased intraosseous pressure, which is an incredibly important element in the development of osteomyelitis, because that's what gives you further ischemia and winds up leading to bone death. And necrosis winds up being the biggest problem that you're dealing with because that deprives you of the ability to get your antibiotics to the infective site. The additional mechanisms from the microorganism standpoint is that the organism seeds the medullary bone now. We're talking about hematogenously. So the organism gets there to the medullary bone because that's where the blood supply is. They multiply, they invade. And keep that in mind because when we're talking about bone infection that arrives from contiguity, okay, then you're going to be having organisms arrive at the bone from the cortex and work their way in, as opposed to from the medullary canal work their way out. And that has everything to do with how you read the x-rays and what impact different findings on x-ray have in terms of your diagnostic ability. So the organisms are there in the medullary area, and then they multiply, invade, they give local metabolic acidosis and edema, which then further increases the intraosseous pressure. Then you get leukocyte activity, which gives you further tissue ischemia, and then venous thrombosis, as we talked before, increases the pressure, and you wind up with necrosis. And in the old days, they used to call that a sequestrum because the dead bone separates itself out from the surrounding bone because it has no blood supply. And the infection spreads from the medullary bone toward the cortex. Okay, it's going through the line of least resistance, so it may not be a straight line, and it may be quite a serpentigenous route. And then when the bone cortex is breached, you wind up with subperiosteal abscess, and then you breach, and then you irritate the periosteum. The periosteum, when it becomes inflamed, starts laying down linear bone in parallel with the bone and the periosteum. And then the extensive amount of new bone formation, if it winds up being something that's visible on X-ray, is called an involucrum, and I'll give you some examples of that. And then when it breaks through the periosteum, then the organism now is invading into the tissues that surround that particular bone. So the first thing that happens on X-rays is you see lucency, and you can see lucency on the X-ray here, and that represents loss of calcium, which is a direct relation to the inflammatory response that's occurring there. And that's very specific when it's in the proper clinical setting, but in and of itself, just looking at an X-ray, it doesn't really have much specificity for infection.
You can use the mouse for
Thank you. Okay, so now here's a very young child, and here is a huge amount of linear bone that has been laid down near the metaphysis of this femur, and you can see that this is a beautifully formed involucrum. Okay, this is periosteal new bone formation, and you're seeing it two-dimensionally, but you have to imagine what this is a circumferential amount of bone being laid down there. So this is a collar around the femur. And here is such a well-formed collar on this patient's humerus that the involucrum, which the arrow is on now, has replaced the integrity of the humerus. And this is the original humerus that the child was born with, and this humerus is now all a sequestrum. This is all dead bone in here, and the usefulness of his arm is totally related to this collar, this collar of well-formed involucrum, periosteal new bone formation. So if you're looking teleologically in terms of how the inflammatory response in periostitis developed in us, there's a very important protective mechanism that winds up giving you a new bone. Periosteal new bone formation, here's a new bone, okay, created. And now these pictures are from people who actually came in because we're a port city. They came into New York. They came from countries where they were not able to access antibiotic therapy. So these are very, very well advanced chronic processes here. But it's good to see how things evolve. And then from the necrotic end, when bone dies, it winds up, if it dies really quickly, it dies before it can lose its calcium. Okay? Calcium is dependent upon an intact blood supply to be removed from bone. And therefore, if the bone becomes dead, necrotic, prior to it being able to lose its calcium, it will have all of its calcium. And here's a better example. It will have all of its calcium, and it will no longer have a blood supply, so it will be hyperdense compared to the surrounding tissue. Okay, it will lose the low-density vascularity, and it will have all its calcium. It will be surrounded by an area that's relatively lucent, because that's bone that died more slowly, got a chance to lose its calcium before it totally lost its blood supply. And then you have other bone that surrounds it, and then all the way out in the edge here in the cortex, you see, again, periosteal new bone formation. Okay. In adults, the same processes go on, but instead of involving the long bones, they involve the vertebra. And that's because the vascular supply, after the growth phase is completed, winds up being higher in the vertebral bones and the pelvic bones and the shoulder clavicles, as well as the vertebra in adulthood. So there's a process called senile hyperemia, which means that as you age, you're getting more blood supply to the vertebral bodies and the shoulder and pelvic areas as well. The more vascular anterior vertebral end plate usually gives a statistical advantage that hematogenous osteomyelitis of vertebra will usually present with anterior vertebral abnormalities on X-ray. And there's a theoretical involvement of Babson's plexus, which is the ability of pelvic veins to communicate directly with spinal veins. Pelvic veins coming from the urinary tract and the prostate gland. And this is definitely true in rodents that have a rubber band around their belly to increase intra-abdominal pressure. Beyond that piece of data, nobody knows anything to be true. But because there is a high relationship between the spread of prostate cancer to vertebra, okay, and it's usually the lumbar vertebra, then there's this thinking that this Babson's plexus may actually operate from a neoplastic standpoint. And as I'll give you data later, you'll see that urinary tract infections and manipulations also associated with urinary pathogens going to lumbar vertebra in terms of infection. So Babson's plexus may actually be operational. The intervertebral disc is very important. It becomes avascular by about age 21, and its nutrient supply is dependent upon diffusion of nutrients from the adjacent vertebral end plates. So when the when the vertebra becomes involved in an infectious process, the flow of those nutrients is diminished, and the disc winds up degenerating due to lack of nutrition. That degeneration then decreases the space occupied by the disc, and you get disc space narrowing, which is identifiable on X-ray, but also allows for further spread of the infection from one vertebra to another. And so vertebral osteomyelitis commonly involves two adjacent vertebrae. This is a lateral chest X-ray, and I'll have better X-rays to show. But basically, we're looking at interspaces here, vertebral, intervertebral spaces here where the disc is, and they're nicely maintained until you get down to this one here, and then that's gone. And that's not as good a demonstration as this one here would be. And hopefully, this is projecting disc space, well-defined and maintained disc space. And then you can see how narrow this disc space is in here because you've got disc space narrowing, which, as I say, is the earliest X-ray finding on the spine for infection. And here's one on a PA view showing good disc space and then no good disc space here. And you can see that the vertebral end plates are already starting to become irregular. As time goes on, if you have a chronic pathogen that will persist and not cause such symptoms that would bring the patient to acute medical attention, then subacute pathogens, classically tuberculosis, but equally commonly or equally evident with anaerobes and slowly growing regular bacteria, non-mycobacteria, you can get a huge amount of sclerosis in the bone, and you wind up getting degeneration of the vertebral body itself, and you can see how much of this vertebral body has been lost. So I'll use this slide here to make sure that I do remember to mention to you that when you're working up somebody with vertebral osteomyelitis, you should always think about tuberculosis to be whether or not that patient should be one that you should be suspicious of or not. That's an automatic. It doesn't mean they have it. And in this country, in this day, that's not a common entity anymore. But if we don't think about it, we'll never diagnose it. So this is hematogenous osteomyelitis, which means that the organism got to the vertebra through the bloodstream, and it got there because there was a primary process elsewhere that allowed the organism to come into the bloodstream and get to the vertebra. And in about 37% or so, we can't figure out where the primary process was. Of the remaining, about half of them are genitourinary tract infections and genitourinary procedures, like cystoscopy and the like. So that brings in the Baptist plexus and also brings into the mind the fact that this is not a predictable pathogen. Okay, so that it could be anything that could have been involved in the urinary tract, and that plus the fact that Staph aureus represents about 50 to 55% of vertebral osteomyelitis just makes the point that you can't predict what the pathogen is going to be in this setting. Just as we talked before about the long bone osteomyelitis, when it breaches the cortex, it goes out into the soft tissue. Well, the vertebra, depending upon what level of vertebral involvement you have, if you have cervical vertebrae involved, you'll wind up with a retropharyngeal abscess. Thoracic, then you get mediastinitis, pericarditis, empyema. As you get down to the lower thorax and the lumbar area, you wind up with subdiaphragmatic and iliopsoas abscesses, peritonitis, and the entire length you can get epidural and subdural abscesses and meningitis. The most feared complications of vertebral osteomyelitis. And then the one that is the one that causes the most amount of irreversible damage is when there's spinal cord compression due to extension of infection, vascular impairment, or vertebral body fracture, as uncommon as that is, though. Okay, now the next type of osteomyelitis is that which flows from contiguity, infection in tissues that are contiguous with the bone. These would be patients who have extensive burns and have lost their ability to have soft tissue integrity protecting the bones. Paranasal sinus disease, which gives you cranial osteomyelitis. Periodontal infection, which also gives you cranial osteomyelitis. And then soft tissue infections like felons, which give you finger osteos. Human and animal bites gives you two different kinds of osteomyelitis. If you get a bite, an infection in the soft tissue, then that soft tissue infection can spread to bone by contiguity. If the bite is really deep and it goes into bone, that's a different form of osteomyelitis, and that's actually introduced infection, which we'll talk about later. But the most common type of contiguous osteomyelitis is extension from, on the basis of vascular insufficiency. There we go. And that we break down a little further to say this is from pressure sores, venous insufficiency, arterial insufficiency, and germane to a lot of the patients here who have severe vasculitis on the basis of inflammatory vascular disease, or arteriosclerosis from hypertension, atherosclerosis from cholesterol disease, and diabetes mellitus, and that's the most common cause of patients with diabetes coming into the hospital is actually diabetic foot infections. And that's a classic ulcer that develops in diabetics, but we've seen similar things. We all have in patients with vasculitis. And here the pathogenesis is that you have an ulcer. The ulcer is there because of an underlying pathogenic mechanism. Okay? In diabetics, it's usually neuropathic. In patients who have systemic vasculitis, it's going to be vasculopathy. But failing to interdict that process, the process will continue to evolve until the ulcer gets deeper and deeper and involves the periosteum. When it involves the periosteum will become inflamed, and it will lay down new bone as part of periostitis. And whereas before, when we showed those pictures of periostitis and new bone formation, that was pathognomonic for osteomyelitis in the hematogenous route of infection. When you're talking about infection developing by contiguity, when the periosteum becomes inflamed, it does not indicate the presence of bone infection yet. It means it's on the way. It's made it through the soft tissue and it's gotten to the periosteum. It has not gotten to the cortex yet until you see a cortical defect. And so be careful. That's why we have an advantage over the radiologist in that we know the history of the patient we're dealing with. The radiologists are just going to read periostitis. If we haven't given them enough history, they'll go periostitis, osteomyelitis. That's not really true when we're talking about spread by contiguity. Bear in mind also that there's a very large number of infectious disease people who think that in this setting you should put a needle in and biopsy the bone to see whether or not there's infection there, and if so, what the organisms are. I have drawn this schematic to show you how virtually impossible it is to biopsy a bone in this setting without causing the infection you're trying to diagnose. There's virtually no way of accessing the area of bone involvement without going through tissue that's seeded with the pathogen or other pathogens in the tissue. So that I think is really not a good idea. And I have published that, but there is another side, and there are people, particularly in diabetics, who really think that they should all be biopsied. That's in contradistinction to the patient who have hematogenous osteomyelitis, where I'm a big believer in doing biopsies. Okay? That's a totally different story. There you can do the biopsy without causing the infection. In addition, you can make the diagnosis of what the pathogens are in this bone by sampling the bottom of this ulcer, because if the pathogenesis of the infection is that the organisms are accessing the bone by the presence of the ulcer, then the organisms at the depth of the ulcer will be the organisms that are in the bone. And there's a study that shows that there's about a 75% correlation, and you wind up identifying an extra organism every second patient. So you wind up over-treating by a half an organism per patient when you use a really deep culture swab from this ulcer to identify what the pathogens are. And there are ways of making the diagnosis of bone infection without putting a needle into the bone. We will get to that too. So the third type of osteomyelitis is introduced infection, and that's by direct septic trauma. That would be an open fracture, or like we were talking before, a dog bite or a human bite where they went right into the bone. But the main one is orthopedic surgery, especially when metallic fixation devices or joint prostheses are put in. They decrease the presence of foreign bodies, decrease the quantity of bacteria necessary to establish an infection, and they permit the pathogens to persist on the surface of these avascular materials. Often, in relationship to these materials, the organisms will lay down biofilms. And the biofilms can be produced by the organism, such as glycocalyx, or they can be produced by the host, where fibronectin is capable of being one of those biofilms. The organisms live within those biofilms, and they thrive within those biofilms. And the biofilms represent a barrier to the penetration of antibiotics, of antibodies, and of complement, so that the organism is in a protected environment, and there's very good reason for it to thrive. Here is a surface electron micrograph showing you, supposed to be for dramatic reasons, certainly dramatic in my view, of how thick these biofilms are. And these spherules that you can see here, these are all staphylococci, okay? And they're just thriving in this matrix. And you can understand physically how difficult it is to get antibiotics through that. Thank you very much. We're not going to go over fracture infections. I'm sorry.
Does the organism generate the biofilm, or does the organism stimulate the host to make the biofilm?
Either one is possible. If I go back to that slide. Okay, so what we're saying here, the glycocalyx is a polysaccharide that's produced by the organism, and it's produced in association with adherence to material, to plastics, to metal. Okay, very common with coagulase-negative staph, very common with gram-negative bacilli. On the other hand, host-derived fibronectin is, as a host responds to the presence of the organism, winds up laying down fibronectin, which then winds up being a protected environment for certain organisms. For other organisms, it winds up being an interface that prevents the organism from adhering to cells. But it's a double-edged sword. Some organisms are prevented from causing infection, while others are permitted to do so and actually assisted in so.
We're videotaping this, so please
Diagnostic approach in terms of osteomyelitis is highly dependent upon the form of infection. So that you have to choose your devices, your imaging devices, very, very carefully with some knowledge about what they're showing you and what they're likely to be vulnerable to in terms of lack of specificity. So X-rays and CT scans have a lot of specificity, but they lack sensitivity. So in somebody who has a super acute infection of the bone, okay, they're not going to be all that helpful because they're not adequately sensitive early on. So in acute hematogenous osteomyelitis of children, X-rays are not of much value, except to show that there's no other pathology going on. And there they have to use scintigraphy, okay? But in adults, we don't have that problem because when vertebral osteomyelitis presents, it's almost always with many weeks of symptoms prior to their presentation, and we can use the X-ray for making diagnosis because it's already become sensitive, because the passage of time has provided that sensitivity. Scintigraphy, very nonspecific. Technetium bone scans, very, very sensitive, very, very nonspecific. Useless except in pediatric acute hematogenous osteomyelitis where the X-ray is normal. They do this technetium bone scan to confirm their clinical diagnosis and then do a biopsy and make the diagnosis. Gallium scan, very variable, cannot carry the burden of making a diagnosis here. And when I was giving this lecture a year ago and earlier, I would have told you the same exact thing about indium scans. They're not sufficiently specific. But people have actually looked at the indium scan, indium leukocyte scan now, and looked at it in terms of separating out the axial skeleton from the more peripheral skeleton. And they show that with the axial skeleton, it's worthless in terms of making the diagnosis of osteomyelitis because there's background bone marrow uptake. So any tissues that have bone marrow active in them, the indium scan is not a really good choice for osteomyelitis because it'll be too nonspecific. But in the peripheral skeleton, in the extremities, where we need it for vasculitis patients and for patients with diabetes, it really does have value. And so this is the first time that I can say anything positive about scintigraphy related to making the diagnosis of bone infection. And it really has shown some value here, and we're now starting to use that.